everybody. I'm so happy to be here. I am a pediatric nurse practitioner and a certified nurse midwife. And back in the day, I was a lactation counselor, but I've cared for women and children with HIV for about 30 years. So I have a long experience of caring for pregnant women with HIV who then were not able to make these choices to how to feed their infants. So it's very exciting to have these changes in North America. Do I get to make these move? Oh. Okay. There we go. So I was working at the University of Colorado in Denver, Colorado for about 20 years, up until about 3 years ago when I went to work at the Cizik School of Nursing in Houston. And we were encouraging or recommending having discussions with women and people who are pregnant with HIV about infant feeding decisions. In 2017 was the first time we started to support people with HIV breastfeeding. So we actually, one of these articles here, we wrote up that experience of developing that program in Colorado. And then, as you know, the guidelines changed officially in the United States in 2023. We wrote an article here about sort of the review of the guidelines and talking about relational decision-making as opposed to the shared decision-making you hear talked about. Relational decision-making comes from a more midwifery perspective where you're thinking about not just the patient and the provider, but it's the patient, the child, the mother-in-law, the father-in-law, the church, the politicians, everybody who's part of your life helping you make these decisions. And we have a paper that we just published in Breastfeeding Medicine about this lactation support that I'm going to be telling you about today. You guys just heard a lot about the background, so I'm not going to go into it too much, but it is exciting that over 99% of the people who actually choose to breastfeed will have an extremely low risk of having a child born with or acquire HIV. We know there's numerous health benefits for breastfeeding, including bonding, infant nutrition, and immunological support. What we haven't talked about today is how important lactation consultants are to this process, right? So it's super exciting to think about a lactation, and a lot of programs will have lactation consultants who meet with our program in Colorado. We had them meet with the women when they were making their decision, when they were still pregnant. We had them meet with them on labor and delivery after they had their baby. We would do a visit postpartum when they came with their baby for those checks. And those bonds with that person who was helping them support lactation were really important. But we found we really had to train the lactation consultants because there's different nuances when you're supporting someone with breastfeeding with HIV than supporting someone without HIV. So that's what brought me the idea of kind of looking, what do lactation consultants know in North America about breastfeeding and HIV, and how do they perceive this, and how willing are they to support people with HIV? What is the level of stigma? So we developed this study looking at those things. So we ended up coming up with a survey that collected we used a general HIV knowledge survey that already existed, but we had to create one that looked at HIV knowledge and breastfeeding. So we did that. And then part of the Stigma survey asks things about willingness to support people with HIV who are breastfeeding. And then, of course, we also collected information on Tele-Lactation. So that's when you're doing lactation consultant through telehealth, experiences and attitudes. It was a cross-sectional mixed methods study, included lactation consultants in North America, so United States and Canada, and they had to be certified for at least 2 years, and it's hard to become certified, so it doesn't mean they only were working for 2 years. Usually it's working for several years before the 2 years of certification. They completed these scales. I have a QR code because you might want to see the scales, and I don't have time in the slides to show them to you. And then descriptive and inferential statistics were used, and inductive thematic analysis for the open-ended questions. We had 207 lactation consultants who were certified. Almost all of them were from the United States, but 13% were from Canada. Most of them were over 35 years old, so they were a group of people who were older, a largely white population, however, 5% Black and 3% Asian, 14% were in different racial and ethnicity categories. Only one person identified as male, so everybody identified as female except for one person. 99% of them had the IBCLC international certification, which is really, really hard to get if anyone knows. It's not an easy certification to get. 58% had more than 10 years of experience. So these were really experienced lactation consultants on this study. Most of them had no experience supporting breastfeeding in people with HIV. In fact, the 25 or so percent that did, we asked like how many had experience with 1 to 5 people with HIV, and then we asked like 6 to 10, and then we were like more than 10. And really, most of that 25% was 1 to 5. So it's only like 2, I think, that had a higher number that probably worked in HIV clinics. The rest of them is like their only experience, if they had it, was maybe with 1 or 2 people. So what we found is that lactation consultants with HIV-related experience, the mean score was 12.6. Those compared to those without experience, with a mean score of 10.2, had significantly higher HIV breastfeeding knowledge. So if you had experience working with someone with HIV, you were more likely to have the knowledge that you needed, and that tracks, right? It makes sense. It's what we want to see that. This just is exact same information I just said, but giving you a little more data. We ended up standardizing the scales and got the same information when previous to standardizing them. So with HIV knowledge, the mean general knowledge, this is already a validated scale looking at HIV general knowledge. Everyone did really well on that. So these lactation consultants know their HIV. They know those answers. The maximum 10, the mean was 9.29. When you added in the breastfeeding and HIV knowledge, they didn't do as well on that. And that also makes sense because it's all new for them, and they don't know the answers. So we're asking things in this question about things like what do you do with mastitis? What do you do? We found even when we were creating it that we didn't sometimes know what the answers were. We would be like, what do you do with mastitis? And we're like, well, there's 5 different ways to treat. So it tells us there's a lot more for all of us to know. So while the general HIV knowledge was high, the knowledge about breastfeeding and HIV was low to moderate. So the mean overall stigma score, so we looked at stigma, was 26.2. And this stigma scale, if it's a higher score equals lower stigma. So I'm going to talk about it with those using higher and lower because it's a little easier to understand. So individuals with a higher HIV-related knowledge had lower levels of stigma. So the more HIV-related knowledge they had, the lower stigma they had. Participants with lower levels of stigma were more willing to support people making these infant feeding decisions around breastfeeding and chest feeding. That also makes sense, right? So if they know more, they have less stigma, and those who have more stigma are less likely to support someone who's making these decisions. Therefore, if they know a little more, maybe their stigma's a little less, they're going to be more apt to want to support people. But I think really important is that 98%, we asked them very specifically how, if you were willing to support someone, and not, even with all of this, 98% of the people who answered said they would. This also just what I just said, but on a slide where you can see a little bit more of the detail. And we did, again, in this slide, I'm showing you the standardized stigma score. And this is also the same data that I just shared with you about breastfeeding, HIV knowledge, and stigma. So then we did, it looks like there was a little movement of my words. You can still see it. Then we had open-ended questions where they could answer and talk about their experiences. And the main theme that came out from those open-ended questions was this emphasis on tele-lactation's potential to improve equity and access and specialized support. So there was really when they were talking about tele-lactation, they were saying, like, this is a way to really reach people who are harder to reach, whether they live rurally or they don't live rurally, but they're at home with like 3 other children, or they don't have as much support, or they don't have a car to get to an appointment, they can't get into their pediatrician's office, they need help, and it's late in the evening, and it's the only time they can connect. So there's like many reasons why tele-lactation was actually very important. So 91% said it improved access, the ability to see the best possible provider regardless of geography. I loved that quote because it says, we could actually come up with a group of really talented, experienced tele-lactation people that could be available to people around the world. Like, it wouldn't just have to be people in your own area. Flexible scheduling, patient may be more likely to schedule regular visits if they didn't need to travel. It saved time. New moms don't always have time to come in for a visit. They almost never have time for that. Reduced exposure to illness. So this came up a lot with, obviously, keeping newborns and the moms healthy at home versus going into a clinic. So the tele-lactation barriers, lack of hands-on support was the main thing. And that makes sense, right? If you're a lactation consultant, you really often need to be examining the infant's mouth, examining the latch, examining a breast. And not being able to do that right in person is one of the biggest barriers. It can be hard to examine the baby's latch, positioning, nipple trauma when you're on telehealth. You have to work harder to connect and understand what else might be going on. So often it's like there's more going on than just the breastfeeding, right, with a new mom. Like if you're a lactation consultant, you're really assessing like postpartum depression and how are you feeling and are you eating enough and who's supporting you? Is the house filled with like baby diapers everywhere. Like you're kind of assessing a whole situation. Those are the things you might lose with telehealth, and you need to probably have more skills to try to get at that. But 96% were open to tele-lactation training, even those that had training already. So in conclusion, lactation consultants with lower HIV stigma demonstrated greater HIV knowledge and willingness to support breastfeeding, chest feeding in women with HIV, underscoring the importance of education in reducing stigma and improving care. Tele-lactation offers innovative, accessible approach to supporting mothers with HIV while advancing equity in care. This study highlights the urgent need for specialized HIV education to address stigma and knowledge gaps. And inclusive informed practices can improve infant feeding outcomes for families impacted by HIV, demonstrating tele-lactation's potential role for promoting health and well-being. So the next step of this is that we're taking this information and developing a program. There's a really robust program doing tele-lactation out of the University of Rochester, where they already have this in place. And what's so nice is that a woman can just go online themselves into their MyChart app and just say, I want a tele-lactation visit. It's super easy. You don't have to call anybody, and they schedule it themselves, and then they have this online visit with a tele-lactation person. So we're working with them to identify a peer program where peers could be trained to be lactation consultants, which would be amazing, to have somebody who'd already gone through this be able to do the lactation consultant support, and include a postpartum intervention for mental health, since mental health, postpartum depression is higher in the communities of people who are living with HIV. So we're looking at kind of growing this into a more of a robust intervention and a study that we can kind of use going forward. And I have to thank all the people in Colorado that I worked with, but also at the Cizik School of Nursing and Baylor College of Medicine, who've helped with this study and all the other work that we're doing in the world of breastfeeding and HIV.